Okay, I guess we'll get started. Good morning. My name is Gene Sung from Los Angeles, California. And my co-moderator is Paul Vespa, also from Los Angeles, but at a lesser university. So who are competing universities. Today's topic for this session is the neurocritical care from the women's perspective. And we'll begin with the first speaker.
Great. Thank you. Do you have the slides for Dr. Alka-Kroom? I will introduce Siam for you. So Dr. Alka-Kroom is an associate professor of neurology at the Division of Neurocritical Care in the Department of Neurology at the University of Miami in the United States. And he is a neurointensivist and an electrophysiologist as well. And he is going to be talking today about subarachnoid hemorrhage and pregnancy.
Can you guys hear me well? Okay, good, perfect. Good morning. Thank you so much. So today I'll talk about subarachnoid hemorrhage and intracerebral hemorrhage during pregnancy. I have no disclosures, but I should say that historically, the epidemiological studies for maternal stroke in general, whether they're hemorrhagic or ischemic, they've been really hampered by lack of high quality data and variable definitions of stroke and differing definition of the postpartum period. So we don't have a really good high quality data on this topic. But I think it's really important to understand from the physiology and pathophysiology standpoint what's happening during pregnancy. So we have increased blood volume by 50%, and I think all these factors influence the risk of intracerebral hemorrhage and subarachnoid hemorrhage. We have reduction in hematocrit. We have increased cardiac output by 50% from baseline during the first stage of labor. Increase of MAP to 20%, up to 20% during uterine contractions. And we have increased brain blood barrier permeability in the presence of hypertension. And I'll show you some figures for that. And then as the gestation progresses, the middle cerebral artery flow decreases and the cerebral blood flow decreases as well. So those are really important factors to understand the pathophysiology behind stroke in general, and more specifically hemorrhagic, whether it's intracerebral hemorrhage or subarachnoid hemorrhage in pregnancy. So we can, let me see if this works. Yeah, maybe. So we can see here some of the remodeling that happens during different pathologies, during also pregnancy and during preeclampsia and chronic hypertension. You see here in normal situation, you have a normal lumen diameter and then the wall of the vessel as well. And those represent of the capillary and the glia. And in chronic hypertension, and we know that well, you have a thickening of the wall of the vessel, cerebrovascularly. And then in pregnancy, because of the elevated progesterone and the relaxing, that leads to systemic vasodilation. And then you see that adaptive outward remodeling. And here you see the larger lumen and this thinner wall. With chronic hypertension and pregnancy, you see the thickening of the wall, but also the reversal of inward remodeling. And then you see microbleeds, perhaps a bit more, and that's obviously put the patient at risk of increased risk of intracranial hypertension or an intracranial hemorrhage. And then during the preeclampsia, then you have no thickening of the wall because it's not hypertension, and you have increase of the lumen diameter, so no inward remodeling with increased glia and inflammation as well and the microbleeds. So all these factors together that happens could put the patient in these conditions, whether it's chronic hypertension, preeclampsia, under increased risk of hemorrhage. So the epidemiology, this is a serious problem. The incidence of stroke in women during pregnancy and postpartum period is approximately triple the incidence of non-pregnant women in the similar age. And half of the strokes are hemorrhagic, which is usually not the case, right? Most of our strokes are ischemic and a small portion of it are hemorrhagic. And most strokes occur between day prior to delivery and 2 weeks after delivery, with vascular lesions usually occurring during pregnancy, or at least we discover them with rupture aneurysm or AVM during pregnancy, and hypertensive hemorrhages postpartum period. So it is a serious problem. Half of the patient with hemorrhagic stroke have a residual deficit, will have a residual deficit, and mortality is up to 50% in these cases, with overall increase of 100-fold in mortality. So I'm going to do 2 cases, one on intracerebral hemorrhage, one on subarachnoid hemorrhage, and we can go through the different etiologies that you could see in either case. So this is a 21-year-old woman, G1P0, presented to labor 3 days after delivery, reporting severe headache and blurry vision. Her blood pressure was 182/110, nearly double her typical baseline, and she was drowsy but oriented. And basic neurological exam was reported normal. While waiting to be transported to high-risk maternal unit to start IV magnesium for presumed preeclampsia or preeclampsia by the definition or by the criteria, she vomited, then lost consciousness and had a generalized convulsion. So this is her CAT scan. So we see that intracerebral hemorrhage, left basal ganglia, and we see hemorrhage and significant cerebral edema and herniation. So for intracerebral hemorrhage, it's probably the direct cause in approximately 1/3 of preeclampsia cases or death. Also seen with posterior reversible encephalopathy syndrome, which is highly associated with eclampsia, and we will have a talk on preeclampsia and eclampsia by Dr. Sana. And ICH may also be due to rupture pre-existing vascular lesions, so such as AV malformations, aneurysms, cav mal, and also Moya collaterals. So the second case, a 40-year-old woman admitted for the treatment of preeclampsia, severe features including headache and blurred vision as well, and postpartum day 5. Her symptoms persistent after treatment with magnesium, got consulted, was found to have a right superior quadranopia. Transcranial Doppler showed vasospasm in the left middle cerebral artery, left posterior cerebral artery, and this is her MRI, which we see here in the FLAIR images, edema, also subarachnoid hemorrhage, and the same thing here for the gradient echo imaging, or SWI. And the angiogram shows a diffuse bidding of the vessels and spasm. Yes. So you can see, let me see if I can, no, not working, but you can see diffuse middle and even smaller caliber vessels. So subarachnoid hemorrhage is more often seen in the setting of reversible cerebral vasoconstriction syndrome, or RCVS. The bleeds tend to happen in the cerebral convexities versus your aneurysmal subarachnoid hemorrhage that happen a bit more deeper around, not on the surface. So if we talk about the reversible cerebral vasoconstriction syndrome, that's a large, medium-sized cerebral artery problems or vasospasms. And thunderclap headache usually is the feature from neurological manifestations, and typically triggered by different events with sympathetic surge, serotonergic medications such as cocaine, antidepressant, or postpartum state, which probably account for about 20% of the cases, and more common in patients who have preeclampsia, possibly because they both share the same pathophysiologic mechanisms. So that's one etiology that could cause a subarachnoid hemorrhage. Cerebral vascular malformation that we spoke about, that's another etiology, although I should say that there's significant selection bias and publication bias from the literature. So if you look at intracerebral hemorrhage, for example, AVM accounts for 5.8 percent of cases. And CAV-MAL is another etiology for this. So for cerebrovascular malformation, when it's present, regardless of what type of vascular lesion you see, hypertension is probably the likely increased risk of rupture and hemorrhage, and that should be definitely detected early. The treatment, we don't have really clear guidelines on what to do with these cases, but probably preemptive interventional treatment should be decided case-by-case basis on the risk of rupture and collaboration and multidisciplinary team between the OB team and the neurosurgeons as well. And no evidence showed that the cesarean delivery decreases the risk of rupture of vascular lesions in pregnancy. But again, does that mean you don't do it? Of course, like it has to be decided in a multidisciplinary manner, especially in this high-risk cases. Another etiology that we could see in intracerebral hemorrhage and in subarachnoid hemorrhage is moyamoya disease. That's progressive steno-occlusive cerebrovascular disorder that affect the terminal internal carotid arteries and the intracranial branches as well. And that lead to both ischemic stroke and as well hemorrhage. And the postpartum strokes are usually ischemic, but during the period of pregnancy, usually that's more hemorrhage or hemorrhagic. And specific cases of some patients, probably surgical revascularization or bypass, STA, MCA bypass before pregnancy may be beneficial to decrease that risk in severe cases. We will have also talk about cerebral venous thrombosis, so I don't want to go into details, but that's another reason that you might have subarachnoid hemorrhage and intracerebral hemorrhage from all the factors that I presented initially and the physiologic changes that is seen with pregnancy, and that could lead to infarction, ischemic stroke, ICH, or subarachnoid hemorrhage. And preeclampsia is also another risk for that. Again, I don't want to spend so much time on this because we have a separate talk. But again, overall treatment consideration, this is a problem that can be solved by one discipline. This is a multidisciplinary management required cases in pregnancy. And blood pressure management or reversal of coagulopathy, avoidance of complications of vasospasm is similar management to what we see with like some exceptions that I'll present soon in non-pregnant women. So pregnant or postpartum patients with acute hemorrhagic stroke should be cared in neurocritical care when possible, and I understand that might not be possible depending on the resources available. Blood pressure is similar to the guidelines in non-pregnant women, but however, I have to say that lowering the blood threshold could be a risk for the fetal, so that has to be discussed with fetal medicine and OB as well, and with fetal monitoring. So a lot of those patients that we have in our unit, they have continuous fetal monitoring to make sure we're monitoring the fetus. Magnesium for seizure prevention of in preeclampsia, and we have the MAG-PI trial. Surgical or intravascular intervention should not be delayed because of that pregnancy status. And obviously we have to minimize the fetal risk or effort to minimize that. The other important consideration for management is intracranial pressure during pregnancy. And I think besides what we usually do from head of bed up and left lateral displacement probably sometimes is needed to decrease the pressure on IVC and subsequently lead to worsening intracranial pressure. Brief hyperventilation if needed, again with fetal monitoring. And in terms of hemodynamic management should focus on optimizing cerebral perfusion pressure, avoiding hypotension, again for fetal risk. And mannitol is safe in pregnancy, and we have more data actually in mannitol than we have in hypertonic, saline. But I think it's safe, and we've definitely used it in Miami for increased intracranial pressure during pregnancy. So this meant to be a small font, although it looks pretty good here. But there big list of medications that should be avoided, and I think, again, that's when the multidisciplinary team approach comes to the table, with working with the pharmacist closely in these cases and with OB closely with these cases to make sure we're using the right agents. So in summary, high maternal morbidity and mortality with intracerebral hemorrhage and subarachnoid hemorrhage in pregnancy. Preeclampsia is commonly associated with both intracerebral hemorrhage and subarach, and we will here talk about this. Management should include a multidisciplinary team. It's critical to work closely with the unit pharmacist, again, for the medication that is used and to make sure it's safe during pregnancy. And surgical intravascular intervention should not be delayed because of pregnancy status, but should be discussed in the multidisciplinary approach. Thank you.
Thank you very much. We'll have all the questions at the end of the session.
Perfect.
For all speakers. Thanks. So our next speaker is Dr. Walter Vedetta. He's the head of section and coordinator of the Adult Intensive Care Unit in Posadas Hospital in Buenos Aires. He obtained his training in internal medicine, intensive care, and neurocritical care in Buenos Aires. And he's the founder and president of LABIC, Latin American Brain Injury Consortium, and he's the director of the National Course on Neurocritical Care for SATI, the Argentinian Critical Care Society. And his research interest includes neurocritical care and mostly traumatic brain injury.
Good morning. Thank you for the invitation to the organizing committee, and particular to Dr. Yasser. So, it's a rare CVST, as the doctor says, a rare form of stroke, but it happens, not so often, but particular at the end and also in the postpartum period. So we need to be aware that it happens and do the right, have a high clinical suspicion and move forward. No? So it's seen in young patients. The incidence is 0.2 to 0.5 for each 100,000, young female, of course, and it's multifactorial. Some changes occur during pregnancy and during the postpartum. As I said in the third point, the clinical diagnosis is difficult. Sometimes it's in the first 48 hours is confused like preeclampsia or eclampsia. So it delayed the treatment, no? So it is because you need to go to centers that have more expertise in the evaluation of this patient. Because if we lose 2 days, the prognosis is worse, no? So this is something that during the pregnancy, some factors go down and others go up, and particular 3 importance: protein C, S, and antithrombin 3, and also antiphospholipidics. Obviously, this is more important in some patients that have chronic inflammatory bowel disease. And so, about the clinical presentation, in 74–75% of the cases, headache is the first presentation. So it's nothing in particular, but we need to do the right question for understanding that it's the first symptom usually, and it's particular. And if we have headache plus vomiting, we need to suspect this. And seizure also is very important in 40–50%, nothing different in the treatment, no? So there is the treatment phase and the prevention of the recurrence. In the treatment phase, anticoagulation is the most important. Mechanical thrombectomy and Alteplase are alternatives, but anticoagulation with low molecular heparins is okay, enoxaparin. So in some cases we have increased ICP, nothing. We need to do the right diagnosis and put an ICP catheter. Is minimally invasive, and do the management according to that. Obviously, if it's have an ischemic and hemorrhagic form, but the hemorrhagic form is have some volume, we need to consider to do some surgery. The seizure treatment is nothing different to other pathology, and the prevention of further thrombosis need to be continued months, and some authors say many years, 2 or 3 years. So enoxaparin is particularly the drug with good safety profile, is bioavailability and long plasma half-life, and don't cruise the placenta, and also doesn't affect excreted in the breast. So it is some few articles with with many patients start to study rivaroxaban and other modern anticoagulants, oral drugs, but it's not a lot of evidence. In general, for this particular pathology, almost the literature is case reported or series of cases. So someone advised, in case of decide or you consider this as previous was said, the multidisciplinary approach. And sometimes you need to decide if you need to use pharmacological and vascular treatment. This decision is no different to other considerations to other patients. And in the last is a mechanical option, is mechanical thrombectomy with a stent retrieval and plus aspiration technique. So these are not many options, but anticoagulation is the first one. The mortality change between the different case of serious cases. Mortality may be 2%, 5%. Someone say 27 or 33. So early diagnosis is the better prognosis. The image that is preferred is MRI with angiography over the CT scan with angiography. So it's more clear. We can follow the patient. So as I said, the misdiagnosis is preeclampsia and eclampsia, and probably we can lose 2 days before ready to the right management. So, no so much. The German group at Day2 the last year, 2 years ago, and was published the last year, guidelines for CBST. Are some new recommendations. There are not a lot of evidence of bibliography done that, so consensus was necessary, and have some new recommendations for someone that want to go deeply in this area. Thank you.
Thank you, Walter. Okay, so that was a great talk. We're going to move on to Dr. Mark Engel. Welcome him to the stage. Dr. Engel is a fellowship-trained intensivist, both in pulmonary medicine, critical care, and anesthesia. And he was the longtime director of the Montreal Neurological Institute and associate director of professional services at McGill University. And he continues to be active full-time in anesthesia and critical care. And we welcomed him to the stage while he gets his slides set up here.
Good. Thank you. Good morning. Thank you for coming. I thank the organizers for inviting me. It's best Canadian slang. It's been a hoot. I have really no disclosures on this topic, save that I am not an expert. Okay. I have in fact seen 18 cases. I've checked our records, 18 cases over the last 15 years, which makes me probably more experienced, but I do not claim an expertise in this disease. The NMDA receptor has been in our consciousness, both literally and figuratively, since the 1960s when it was first described. Since then, we've learned that it is highly expressed throughout the CNS system, though a lot during limbic structures. It's also in the peripheral nervous system where it takes part in pain processing. It primarily is involved in neuromodulation, presynaptically as a modulator, postsynaptically as an effector. It's responsible for long-term potentiation and long-term depolarization, which are two processes that underwrite memory, learning, and neuroplasticity. It also has odd effects on mood. It has some associations with psychiatric disorders. It has been associated with several neurodegenerative diseases, and so it sparked the interest of pharma for about 40 years. Despite the fact there's been very little issue, there are very few drugs related to it because fooling with the NMDA receptor is not for the faint-hearted. Now we know that transient and gentle depression of NMDA receptor activity can actually be quite amusing. It underwrites some of the experience of cannabis, alcohol, nitrous oxide, vitamin K, ketamine, and phencyclidine. So it's a recreational activity. Also, if you depress it, again, temporarily and more deeply, it's actually a useful thing to do for anesthetists in terms of ketamine dissociative anesthesia. And it's used right now in treatment-resistant depression as part of ketamine therapy. However, if you depress it profoundly and in a prolonged sense, you have a catastrophic situation called the NMDA receptor encephalitis, which is what we're going to talk about this morning. Now, it's a fascinating disease, and I think it takes a bigger place than it should in neurointensive care because it's incredibly rare. It's been heavily publicized. Books have been written about it. Most famously, it's called Brain on Fire, which is a misappropriation because it's not a brain on fire, it's brain in chaos. When I say it's rare, it's described mostly as about 1.3 per million per year, which means in the United States, probably 400 new cases a year. In Canada, maybe 40. Half of those are pediatrics, so an adult intensivist is only likely to see one of these a year in a referral center. Hence, it's very hard to claim an expertise, and your N value for making observations is remarkably low. That being said, it's incredibly memorable, and dealing with one NMDA receptor encephalitis, you feel like you've dealt with 10. You don't forget. I remember my first one, like my first girlfriend. It's also remarkable that it's a new disease. It's only been described by Dalmo in 2007. Now, we think it existed before, and people have speculated back into the 1830s, but my memory is pretty good, and going back for the 20 years I was doing neuro-ICU before 2007, I can only remember one case in a male that would have qualified. So I don't know where this disease came from. It obviously wasn't being referred to neuro-ICUs. Because it's so new, it's exciting. It's like finding a new number, like 0 by the Hindus, or by finding finally planet 9 in the Oort cloud. But it's exciting. What's also interesting about it is I put this down as an arduous and expensive identification because it takes a long time to a referral lab and cell-based assays to diagnose it. It means you actually have to do a clinical diagnosis and begin treatment before you have verification. And that's kind of bungee cord intensive care that many people are now uncomfortable with. This isn't a lab-dependent diagnosis. You have to make it clinically, and you have to put your drugs where your thoughts are. What's remarkable again about it is because it's new, we don't actually know anything about its natural history. How many diseases do you know where you have no idea what happens when you don't treat it? So if you don't know what happens when you don't treat it, how do you know that your treatments are helping and not hindering? Well, then you compare treatments. But if one treatment is better than the other, does that mean it's less bad than the bad one that you were trying before? We're kind of wandering in the dark with all of our treatments here. The safety factor, and the one that liberates you and sets you free, is that there are no guidelines. Nobody has a clue. We have a variety of consensus statements on how to treat it. The one that's accepted and published in neurology is one that is extended to adults, but it was actually published by 27 pediatricians who then, late in the stage of their consensus, included 2 adult neurointensivists. So they're describing what to do in a pediatric setting, thinking that pediatric NMDA is the same as adult NMDA. And that's an assumption. I don't know that to be true. This is a boring slide. I put it up because it's important to know that there is a diagnostic criteria for autoimmune encephalitis. This is by Grouse in 2016. You need 4 of the 6 to qualify as an autoimmune encephalitis. What distinguishes NMDAR encephalitis is mostly far more movement disorders and dystonias, far more seizures. That being said, I thought I'd color this in with my first case, to give you a flavor. Sorry, how many people have ever seen this disease? Wow, okay. So I'm preaching to the choir. This is a 32-year-old oncology nurse who was 3 weeks postpartum when she started behaving oddly at home. Oddly in the sense that she would forget to feed the baby, she would go outside of the house naked, she would wander in the kitchen with no clear idea why she was there. She became a little disoriented in time and space, some speech difficulties. Family communicated with a family physician who said postpartum depression and gave a consultation to psychiatry. In our province, that takes about a year, and in the intervening week, she developed some delusions, then some hallucinations, and became paranoid. So she was brought to the emergency room, which is often a futile event in the province of Quebec, where they diagnosed an atypical psychosis and started her on typical antipsychotics. She didn't do well, and subsequently slipped into a catatonic state. That precipitated an admission to the floor and preparation for electroconvulsive therapy, but before they could do that, she developed odd seizure-like movements. They moved her to the ICU. They started treating her for seizures. She required intubation. Even after intubation, these odd movements continued. They declared her to be a status epilepticus. She failed on 2 anesthetic agents, and then she was transferred to us. Our typical response to this kind of transfer is turn off all of the drugs, do an EEG, and find out what's going on. What we found was, in fact, she was in delta coma, and that the movements that she was doing were clearly dystonias. We made the diagnosis of presumptive NMDA. We did a lumbar puncture and sent it off for antibodies, which in Canada still means a 4,000-mile journey, 2.5 to 4 week turnover before you get confirmation. And started her on preemptive treatment. We did find in her records that prepartum she was identified as having an ovarian cyst, they thought, so we pursued a surgical evacuation. In the meantime, her dystonias, which had begun as orofacial brachial, became generalized, involving both her thorax, her abdomen, her diaphragms, and she became impossible to ventilate. There was no way of establishing any kind of synchrony with the machine, so we had to paralyze her. And she remained paralyzed for 6.5 weeks, with daily efforts to come off the rocuronium infusion, failing completely. During that time, she got tier 1 and 2 tier treatments that we'll go into. She gradually recovered, and there was a gradual reversal of her precipitating symptoms. She became eyes open but not aware. She developed not a dystonia but a very odd repetitive chorioathetotic pattern which haunts me now. She would sit up in bed, she would have eyes open as if she were looking at you. She would open her mouth and use articulatory movements. She would have a movement of supplication with her right arm as if asking for help, and then she would fall back in bed. And this would be repeated once a minute, 24 hours a day, without ceasing. And this went on for about 2 to 3 weeks. Gradually, it seemed they decreased and she regained some consciousness and awareness of her environment. After about 6 to 8 weeks, she was actually able to move to the floor where she was still frankly psychotic and delusional. She stayed in the hospital for 8 months. She went to rehab. She went home after 15 months, and at 2 years, she was back at her job with a happy child. So it's a memorable experience and a memorable outcome. I can say that it is absolutely classic, but I can say in the 17 subsequent cases, no one has ever looked exactly like this. Every case is individual, every case is different, and they're all remarkable. The pathophysiology is fairly well established. You produce an IgG antibody to the GLU-N1 subunit. There are 2 of them in an NMDA receptor. It actually causes collapse of the receptor body. It tears apart the receptor protein Zephyrin B2, so it dissociates from its membrane, slides into the cytoplasmic sea, sails off awaiting phagocytosis. So what you have is an NMDA-free environment where you get decreased cellular currents. Now what that does is it doesn't give you depression, it doesn't give you excitation, it gives you a complete imbalance, in fact a chaotic state where the cells are no longer modulated and subject to all kinds of influences, and they do what they want. Hence the expression that we see, this excitation, catatonia, dystonia, coma. It is a very odd state. And again, I would call it brain in chaos, not brain on fire. It's epidemiology. This is a kind of women's health, so it's important. It's young. The median age is 23, but that's because 50% are pediatric. And I don't see them, and I don't profess any knowledge whether pediatric experience is different. It's female, 70 to 75% predominant, but it's interesting because only females get ovarian teratomas. If you take away the females that have teratomas out of the population, it's probably equally effective for men and women. What I understood, and I never did before, is in looking at this, it's racialized, and strikingly so. Now, we don't have that data frequently because most reports are from single centers, and not many of these reports, increasingly from China actually, are in diverse populations. But this is from the Kaiser Permanente data in California, which has a very diverse population. And there, the risk in the black population is 3, in Latino 2, Asian 2, and actually the Caucasian is underexpressed at 0.4. This is a person of color disease, at least in the United States. Now, it's always been associated, because it's so striking, with ovarian teratomas, but the association is only about 37%. It's good, it's important, it's large, it's a reason to modulate your treatment and investigation, but it's only 37%. It's telling you something else is going on. There is also a clear association with viral syndromes, herpes simplex encephalitis, Japanese encephalitis, and other things through molecular mimicry. Kind of focusing in on teratomas, because that's the session, it's actually what we call a felicitous association. Dr. Dalmau, who was responsible for an autoimmune encephalitis referral network, received in the same week 2 referrals for patients who had incidental teratomas. He put teratoma and teratoma together, established a disease, looked for it, found a receptor, and voila, we have a new disease, Planet X. The association seems to be also prevalent here. More black females have teratoma-associated NMDA or encephalitis than do white or overall. So there's something genomically, probably, people have postulated socioeconomic factors, but it's probably genomic. The prevalence of teratomas, though, is 10-fold to 20-fold greater than the incidence of encephalitis. And actually, if you take a look at the totality of teratomas, only 1.7% are associated with the disease. So it's an association. Yes, there is causation, but it's telling us something different. No one actually knows the incidence of antibody positivity in people with teratomas. No one knows whether it's an evanescent phenomenon or a permanent phenomenon, or they're constantly pumping it out. But clearly, most people with teratomas don't get encephalitis. So what's happening? Is it possible that we're pumping out antibodies and the antibodies have different toxicities? And the answer, generally speaking, is no, because anytime you find these antibodies in the serum and you inject them into animal models, they get the disease. So anytime you find an NMDA antibody in the blood, it is potentially neurotoxic. Obviously, it's in the blood much more often. In fact, when we do controls, it's 7% of the population that's positive at any time. 7% aren't encephalitic. So the next step is the disease requires that these B cells producing the antibody get access across the blood-brain barrier, create plasmacytes. This is a CNS-based production of antibody. So what we have is the possibility that these antibodies are floating around, and what we have is a concurrent event that opens up the blood-brain barrier, and it's an unfortunate coincidence because the antibodies get in and establish chaos. And what supports that inferentially is that almost everybody with the encephalitis has a viral prodrome of some kind. And you could almost say that if they weren't seropositive at the time, they would just have a mild viral meningitis encephalitis. But if you have this at the time that you are either permanently or spuriously antibody positive, it gets access and chaos. I put biomarkers. It's interesting intellectually. They're remarkably subtle, and what it does show is that this is a disease not characterized by much inflammation. The antibodies are not cytotoxic. The brain is not damaged. We see very few indices of inflammation. We just see what a brain is like when it's unmodulated. Just before I get to therapeutic considerations, which could be short, you could just read the article. The time course is months, okay? And we're not used to that as physicians and intensivists. We look at things in terms of days and responses in terms of hours. This is something that is elongated. Again, we have no natural history, so we have no reference point, what we call in French, point de repère. We know from a little data from Landau, who did have a biobank of 5 people who had positivity and were never checked, that there is a spontaneous recovery, that there are relapses from the spontaneous recovery, and that you are often left with deficits. We can't let that happen because we know that even with treatment, there's a 4 to 10% mortality. And although we say they have a relatively good 80 to 90% recovery based on an MRS or motor functional scale, almost 70% have significant neurocognitive, emotional, psychiatric defects. This is a bad disease to have contracted. And my reference patient who went back to work is the exception rather than the rule, lamentably. Now this is boring, but it's up here because it's a fact. These are the indications for ICU admission, which is hypoventilation, which is a story in and of itself, dysautonomia and seizures, and it's said that 75% gain it. I think this is pediatric literature. What I would say is this is a rare disease. These are young people. We may have an ability to intervene. All of these patients should come to ICU, be observed, and only discharged when they're showing a favorable progression. That allows us to establish in a neuro-ICU, in a reference base, enough patients to make valuable observations and prognostication and vary our treatments. If this remains as a diaspora in general ICUs, we'll never get further ahead. The second part is that when these patients come to the ICU, everyone has to know that this is a marathon. This is the family, this is the nurses, this is the doctor. This is not a day, a week, a month. Everyone takes a deep breath because good responders take 3 months for recovery. Average responders are 9 months for recovery. Poor responders are 18. You can't treat this like an emergency. There is some sense of urgency, but this is the long term. Okay, sorry. Again, one of the problems is that treatment and response are telescoped. So again, when we try a treatment and we don't see a response in a week or two, we tend to either intensify or change the treatments. there is a degree of patience demanded of us as intensivists that is not common. You have to take the time, watch, and have some kind of time architecture, and it's provided within the recommendations, but it has to be modified by your clinical judgment. Overtreatment and iatrogenesis, when you're dealing with a disease that's stretched over this many months, is really the major cause of morbidity, mortality. Another thing that we have to recognize is that with this disease, the brain is wired differently. It's just a different organ, and it doesn't respond to any of the CNS-directed drugs that we use every day in a predictable way. And in fact, it probably doesn't respond to any of them in a way that you're used to seeing. The dystonias that we see, frankly, are untreatable. They don't respond to anything, and you make people worse by trying to give them tetrabenzene and other things. If the dystonia disturbs you, let it disturb you. If it disturbs the airway, then intubate. If it interferes with ventilation, then paralyze. But it will only go away with immune therapy, and it will only go away with weeks and months. Antipsychotics for the psychotic phase, it's not so much a problem in the ICU because, man, they've passed through it very quickly before they come to you. But antipsychotics in general don't work. The ones that I use tend to be the older ones. The first generation thorazine, methyltrimeprazine, which have very little extrapyramidal effects and don't cause and worsen dystonias. But I'm not sure that I would recommend any at any point. There's a funny association with malignant neuroleptic-like syndrome, but I think that's spurious. I've never seen it. Sedation. We had an excellent talk on delirium yesterday, which opened my eyes in a number of directions. But these patients are comatose. And when you give them sedatives, you're giving them sedatives for the dystonia and what looks like agitation and looks like pain, but is actually not being experienced by the patient. And I've seen people on midazolam drips, opioid drips, and they're really treating the nurse's family and you. They're not treating the patient. The patient is in a delta brush. They're somewhere else, Mars, not Earth. What I've relied on in the last number of years is EEG monitoring. At the Neuro, we have the easy access to continuous monitoring. So during the course, we tend to keep them on for 3 days, off for 4 days, to give us a sense of progression and where they are. It's also to rule out seizures. Seizures, I thought at the beginning of this disease, were rare. They were mostly pseudo-seizures. But in fact, we've had 3 or 4 patients with resistant seizures that have not done well. So I've changed my mind over time. Treating seizures is probably not worth your time because they do not respond to normal anti-epileptic drugs. This is a different brain. Now, when you're faced with status, you're kind of faced with a rock and a hard place. You don't have anything to do that works reliably, but these are patients that don't do well, that develop progressive MRI changes whose outcomes are arguably worse. What I've been doing is giving a trial of 12 hours of intravenous anesthetic agents, propofol, midazolam. Do not use ketamine. There might be an advantage of dexmedetomidine because it's as an alpha-1 agent, it's actually an upregulator of NMDA activity. But it's a short duration agent for a long duration disease. So if it works, you might flip over to some clonidine. Other than that, there is some promise of using old-fashioned neurosteroids. Most of you here are probably not old enough to know the drug alpha-thesin, which was a progesterone-based alphatalone, alfaxalone mixture that we used for ICU sedation in the 80s, but is a superb anti-epileptic agent. And it's the neurosteroids experimentally that work best against seizures in this disease. Pregnenolone is only available orally by the FDA, but it's a focus of investigation. The therapeutics, where was I? Are pretty straightforward. It's what we used to call the neurology 3-pack and 6-pack. It's a blind stab. The first one is, well, we've got antibodies, we must get rid of them, so you give pulse steroids. You've got antibodies and we've got to get them out of the system, so we fudge them up with IVIG. You've got antibodies in the system, we must get rid of them, so you put them on plasmapheresis. It's all very reasonable. It has relatively low morbidity, and in fact, you're doing this based on a clinical diagnosis. So you really don't want to do something with significant morbidity unless you have CSF verification. So it allows you a little bit of breathing time until your CSF samples come back. The problem is it's getting rid of the circulating antibodies. It doesn't deal with the blood-brain barrier problem, which precipitated it, and it has nothing to do with the active plasmacytes that are contained with the CNS. You're not dealing with a disease, you're trying to put a hold on it. It's a palliative. That being said, our ability to do much about CNS disease is limited by pharmacodynamics. The recommendations from the pediatricians is that you try these therapies. If there's progression at 2 weeks, you go on to a second tier. And the NIH has actually verified this, and what we now use is rituximab. Sorry, has a mind of its own. Rituximab. And in our experience, and again, it's just observing, rituximab is effective and we get a very good response 2 to 3 weeks after the first infusion. Everything else I'm not so sure about. There's a recommendation to think about using tocilizumab. I have a vowel obstruction when it comes to these biologicals. But this is an IL-6 and it's another mode of attack. And cyclophosphamide has been used as a salvage of a salvage. Now, what has always interested me is why we're not using intrathecal therapy from the beginning. Dr. Pinsky yesterday made a point at one of our sessions that we condemn our second and third tier agents to poor success rates because we're giving them a second and third tier. If you have a definitive medication, why not use it up front? There's a fear about using these potent immunosuppressants, but when people have looked at complications in people who didn't have the disease, who were nonetheless immunosuppressed, most of the complications are related to steroids. They're not related to IL-6 inhibitors, they're not related to the rituximab. So you could make a cogent argument that Ritox should be used much earlier, and then you could make an argument that maybe we should be giving something intrathecally to get rid of the plasmacyte activity, which would mean either intrathecal rituximab, which is a valid therapy and proven to be safe in various pediatric immune encephalopathies, or we could be giving other things that get inside, and I guess the one we have is satralizumab. There are a couple of trials, Yellow and Extinguish, which are in place right now, which are trying these. There's nothing using intrathecal therapy, which I find a little disappointing. Other kind of approaches are using monoclonal antibodies to actually unblock the two blocked receptors, using blood-brain barrier closers to no longer permit access of seropositive antibodies into the CSF space, trying to re-upgrade the membrane bonds of the receptor, the eptin B2s, and finally, neuromodulation with neurosteroids. Those are the pregnenolone-derived anesthetic agents. And so there we stand. We're not entirely sure we understand the disease, we understand the physiology, we are impressed at its expression, we're learning by its expression what the NMDA receptor does, and we're still at the very first stages of trying to treat this disease effectively, or even recognizing that we're being effective in doing so. And I thank you for your attention.
Great, thank you very much. Our next speaker is Dr. Sana Alkawaja. She is the Senior ICU Consultant at SMC, Deputy Chief of Medical Staff for Surgical Services, and Assistant Professor at the Arabian Gulf University. She attained the Arab Board in Emergency Medicine and did a fellowship in critical care from London, Ontario in Canada. And she also trained in toxicology in Denver, Colorado. And she does research and is published in emergency and critical care medicine. Thank you.
Good morning, everybody. First of all, I would like to thank the organizer for the invitation, especially Dr. Yasser. I'm going to talk about the neurological complication of eclampsia. The symptoms of preeclampsia was known since long time back. Hippocrates, he talked about them in 400 BCE. He said that in pregnancy, the onset of a drowsy headache with heaviness is bad. Such cases are perhaps liable to some sort of fits at the same time. So if we are looking at his definition, we find that the most important thing he have mentioned them. If you know this, you know everything about the preeclampsia. He mentioned that there is a headache, it could be complicated by fits, and they have a bad prognosis. The word eclampsia itself was first used in the 18th century by a French obstetrician, Bonsin de Sauvage. He was the first one to differentiate between eclampsia and epilepsy. Till 1990, the diagnosis of preeclampsia was mainly for a patient who is having hypertension and proteinuria. So if the patient does not have proteinuria, they will not say the patient is having preeclampsia. That till 1994, when Douglas and his colleague have conducted a clinical trial and they studied all the patients with the preeclampsia, they found that only 38% of cases healed by hypertension and proteinuria. The interesting thing that they found that the presenting symptoms in this patient was mainly neurological complication. They had headache in 50% and 19% they were presenting with visual disturbance. Not only this, they found that these neurological symptoms, usually they precede the eclampsia by 1 week. So we have a chance to identify our patient and treat them. So from that time, he recommended that the screening and the diagnosis for preeclampsia should consider other things than proteinuria. It's a kind of multi-system disease. So the latest definition of preeclampsia by the ACOG in 2019, they defined preeclampsia as a new onset of persistent hypertension at or after 20 weeks of gestation and either proteinuria or any of these symptomatic complications like low platelets, acute kidney injury, elevated in the liver enzyme, presence of pulmonary edema, new instant persistent headache, or presence of visual symptoms like blurred vision, flashing lights, or scotoma. The pathophysiology of preeclampsia is very complicated and it's very debatable, but the most accepted hypothesis is that there is a primary disturbance of the placental dysfunction. This is mainly because there is an abnormality in the placental vasculature early in pregnancy. This will result in reduced uterine perfusion and some kind of ischemia, and this will result in release of cytokines, anti-angiogenic factor in the maternal circulation, and all of this will lead to maternal vascular dysfunction, hypertension, vasospasm, and all other complications which we are seeing in preeclampsia. Central nervous system is one of the most important systems which will be affected by preeclampsia, eclampsia. These patients, they could present with seizure, headache, cerebrovascular disease in the form of hemorrhagic or ischemic stroke, PRES, and RCVS, and encephalopathy. We are going to talk about briefly in each one of them. Seizure. Seizure is one of the most common presentation we are seeing with the preeclampsia, eclampsia. It's mainly because there is a dysfunction in the blood-brain barrier, or there could be an exposure of the brain to a circulatory pro-inflammatory factors, and at the same time, there is a decrease in the threshold of the seizure. There are specific characteristics of the seizure in preeclampsia. Usually, they are generalized, tonic-clonic. They could happen either antepartum, intrapartum, or even postpartum within 48 hours after delivery. But it's very important to know that the seizure is usually generalized tonic-clonic. If the patient is having any kind of focal seizure, this could be atypical, and this leads us to think that the patient is having other things than preeclampsia. Interestingly, they found that the EEG in this patient is usually abnormal. Even in the eclampsia patient without convulsion, 70 to 80% of the EEG were abnormal. They have different abnormality. It's either generalized slowing or even the presence of epileptical discharges, alpha, coma, or even they could have EEG silence. Headache. Headache is one of the second most common complication of the preeclampsia. Headache by itself is common during pregnancy, but the cause of headache could be varies. It could be something benign, or it could be kind of life-threatening catastrophes, presenting some complicated cases which have been discussed by the previous speakers. Okay, so if we are dealing with a headache during pregnancy, we have to be very careful, because some studies, they have found that the headache, it was the presenting symptoms of preeclampsia in around 87.9%, which is a very high rate. So if we are dealing with headache in pregnancy, we need to be very careful. We need to take a thorough history. We need to do a full examination. And we have a high index of suspicion that this headache is not a benign one and could be a sign of other catastrophic complication. The preeclampsia headache usually have a characteristic feature. It's a progressive, bilateral. It's pulsatile inequality. And it's not going by any treatment. It's aggravated by physical activity. And sometimes it's associated with visual changes, such as blurred vision and scotoma. The interesting thing is that they found that there is a big association between migraine and preeclampsia. The latest study, which was published in April 2023, they found that they have analyzed around 3,500 patients. They found that pre-pregnancy migraine, ladies with migraine before pregnancy, they were associated with a higher risk preeclampsia. Not only this, but migraine with aura, they have a higher risk of having preeclampsia during pregnancy. So our job at the bedside is very important to differentiate between the benign headache and the headache which we need further investigation, so we will not miss any cases. I find that using the mnemonic from the obstetric life support, Scan Me, is very useful at the bedside to differentiate between which patient we need to go further with investigation and which patient we can say it's a benign process. So Scan Me goes S for sudden severe headache, C for change in the position or eye quality, A if the patient is having altered mental status, N if there is any neurological deficit, nausea or vomiting, M if the medication is not relieving the headache, and E if there is an elevation in the blood pressure or temperature. All these clinical features should raise our thought to go with a further investigation and imaging. What is the best neuroimage we can do? MRI is preferred over the CT, but saying this is very important to say MRI is useful if we have the facility. If we don't have a facility, then we can go with the CT. But if we have both, MRI is preferred because it has less radiation than the CAT scan. But we have to be careful not to use the gadolinium-based contrast, because the study, they found that it was associated with teratogenic effect on the fetus. But it's safe to use the IV iodinate contrast because there is no increased risk of any teratogenic effect. Other complications which could happen in preeclampsia include cerebrovascular disease. It's mainly because of vascular dysfunction. It can range from hemorrhagic stroke, ischemic stroke, PRES, or reverse cerebral vasoconstriction syndrome. I'm not going to talk in details about this because the previous speaker, Dr. Raham, he spoke about them. But there is a study which found that preeclampsia and eclampsia was associated with a 4-fold increase of stroke during pregnancy. So preeclampsia lead to more stroke in the pregnant ladies. The second one is the PRES, posterior reversible encephalopathy syndrome. Patients with the PRES, usually they present with encephalopathies, headache, seizure, cortical blindness, plus some focal neurological deficit. This is mainly happen because there is damage to the cerebral autoregulation, there is endothelial dysfunction, and there could be some vasospasm which lead to cerebral ischemia. The typical feature which we can see on the CT, we can see there is a vasogenic edema. It's mainly in the occipital and the parietal lobe. And in the MRI, it's more clear. And from the name, it's a reversible reversible disease, but unfortunately, not all patients, they will have complete recovery. Some of them, they will have some deficit. The second one is reversible cerebral vasoconstriction syndrome. It's a multifocal cerebral vasospasm, which could happen anywhere, and it can lead to ischemic stroke, hemorrhagic stroke, subarachnoid hemorrhage, or even a seizure. The characteristic of RCVS, it's mainly, they will have a recurrent thunderclamp headache, which is a pathognomonic feature. Plus, they could have some focal neurological deficit, mainly because of the vasospasm. The diagnosis, it's usually by CT or MRI, which show a multifocal segmental vasoconstriction on the visual image. But the problem that this vasospasm sometimes is transient, so we will not be able to detect it. The other diagnostic feature could be the transcranial Doppler, which is a non-invasive, and it can assess the arterial velocity, and it's useful for the initial diagnosis as well for subsequent monitoring. Saying all of this, it's very important to keep in our mind that the problem with the preeclampsia will not finish with delivery. There are some complications which will happen even after delivery. This complication will affect both the fetus and the mother. Studies have found that the infant who were born with a female with maternal preeclampsia, they have systemic and neurological complication. They have hypertension, which begin early in childhood. They have increased risk of a stroke in adulthood, and they have a higher risk of developing epilepsy. Not only this, other meta-analysis, they found they have negative effect on their intellectual abilities. They have higher risk of having attention deficit syndrome, and they have autism. What about the mother? Different studies, they have found that there is a long-term maternal neurological complication of preeclampsia and eclampsia. Women with a history of preeclampsia have been recognized to have a higher risk of vascular disease later in life. One study showed that the OR of 1.76 for women with a history of preeclampsia, they will develop ischemic stroke at a younger age group. Not only this, they have a higher risk of having cognitive dysfunction, which may persist even after following their preeclampsia. So the take-home message, preeclampsia are the leading cause of morbidity and mortality among pregnant and perinatal women globally. At least half of maternal death due to preeclampsia can be preventable with earlier recognition, diagnosis, and treatment. Neurologists, obstetrician, intensivist, family physician, and all other clinicians who are taking care of pregnant and postpartum women should be aware of the neurological feature and the complication of preeclampsia, eclampsia, and they should have a low threshold to obtain additional diagnostic tests. Headache is one of the most commonly early presentation in preeclampsia and eclampsia. And finally, please save the brain of the ladies by being careful about any patient present with headache. Thank you very much.
Thank you very much. So all the speakers are open for questions. Are there any questions from the audience? I'd like to start, so this is exactly going to be my first question is, how do we, obviously for all diseases, how do we prevent diseases from even beginning in the first place? So we have some risk factors, particularly history of migraines even before pregnancy for patients. Should there be closer monitoring of all patients then who have migraine headaches even when they become pregnant? Should there be early treatment of hypertension or lower thresholds for hypertension treatment? What are your thoughts? Or
yeah. Yeah, we have to be very careful when dealing with a pregnant lady with migraine. Not any headache, we will see it's because of migraine, because migraine have a higher risk preeclampsia. So we need really to take a full history. We have to do scan when we think this patient could have another causes of headache. Plus, we have to be more aggressive with treating hypertension.
Question? Go ahead.
Thank you for this presentation. My question for Dr. Mark regarding to anti-MDA encephalitis. You said in treatment of seizures, to avoid ketamine. Why to avoid ketamine?
That question could have two dimensions. Okay, the simple answer to your question is that the mechanism of ketamine is profound depression of the NMDA receptor, which is the disease that we have. Okay, so on the other hand, there have been some speculation that low-dose ketamine, even in the absence of the receptors, has a positive effect. It's a speculation, and I've had a couple of my colleagues try it, and the results were ugly. So I don't suggest it at this point. But again, to reiterate, these are very difficult seizures to treat. They don't respond, and I'll tell you from the beginning, they don't respond to the entire gamut of ordinary oral agents that we do. And there's some speculation that we make them worse because it's a different brain. We would need to be in a different world to develop drugs to treat these. And the better part is just to accept that intermittent seizures are going to keep occurring until the disease has abated because of immunotherapy, and to concentrate only on status. And if you're dealing with status, you have to use anesthetic drugs. But
Thank
you're
you.
right, there is slight literature out there using low-dose ketamine as an adjunct.
Thank you.
So I have a question for each of the speakers. If you want to come up, so you can each take your shot at this question. I think the common theme here is one has a pregnant patient or an initial postpartum patient who's in extremis. Each of these any of these syndromes is really an extremis. What do you do first? What's your top priority? Please don't say the ABCs. Give us, what is most important in a time-sensitive critical care fashion that you would say, this is what you should take home as a message? Go ahead.
Yeah.
Why don't you take like an ICH or something?
I saw you looking at me. So I think focusing on the mother care first. And whether that needs surgical intervention, such an intracerebral hemorrhage, fixing the aneurysm, whatever needs to be done, putting the mother first.
Okay, Walter.
Yes, in our hospital we receive from another mother children hospital. First of all, we accept all the patients. If we don't have a bed, we do one. I don't know, different ways. And after we take the patient in the ED, because we know that as we talked before, there are almost of our patients in my area, geographic area, are mistreated 1 or 2 days before for different reasons. It is probably more related to the doctors, and there is another reason related with the question of Jean, that our patients in the lower social economic in our underdeveloped countries, they not access in the good, they don't access to the public health in the right way. It is in time and the doctor. So sometimes it is as preeclampsia, eclampsia, or CVST are more frequent in our countries and underdeveloped countries. I guess that is more related with this, and probably another factor. So.
Dr. Alcuya. Or Dr. Wade. Either one.
I'm interpreting that question as mother or child.
Say again?
I'm interpreting that question as save the mother or save the child.
No, I think just the concept is these are sort of confusing diagnoses. The person's an extremis. What should you do? And I like that. I like your take on it too. If you want to answer that, that's fine.
It's a common situation at our hospital, and I'd have to say that 9 out of 10, the mother will say, I would rather die than put my child at risk. So 9 out of 10 will refuse intervention if there is any risk whatsoever. And if you tell them that the risk for their child is even worse, if the second bleed occurs, they'll say, I'm at ease with that if I die with my child. So although we're all told as physicians that the mother is above the child, and anesthesia, that's what we're told, the mothers will not agree with you. And in fact, nor will the fathers.
I think early detection and early recognition of patient at risk is very important. In addition, there could be a multidisciplinary team, which include the neurologist, the obstetrician, and even the family themselves, the mother herself and the family, to take a decision about the plan of care, where they want to go, how aggressive we can go with them.
Okay, thank you. Question from the audience?
Hi, good morning. My name is Ahmed Bayerli. I'm currently at Cleveland Clinic, Abu Dhabi. My question is about autoimmune encephalitis. Also, it is, kind of rare disease, but we see quite few patients every year. Just happened like almost more than a year ago, 2 patients came in the same time, almost exactly the same, both young Filipino women, no past medical history, the typical presentation. We did all kind of therapy, what you mentioned. One patient semi-responded, but the other patient we're still dealing with. The only problem right now that she has a lot of, this myoclonic activity that affecting her ventilation. And we tried all kind of therapy, really nothing worked. So I wonder if there's anything that we could think about, like, any maybe even experimental therapy at that stage, because we cannot get her off sedation, we cannot get her off ventilator. And one typical thing also that we noticed, the orofacial myokinesia is almost almost typical for those patients.
I was about to say that you're unlucky because had you received those 2 patients in the same day, like Dr. Dalmau, you might have created a new disease. Being less glib, the problem of refractory unresponsive encephalitis is the same as kind of super refractory status epilepsy, which is there are no defined treatments, there are basically case reports. And case reports for people who have been symptomatic over 12 months and who are still CSF positive, they use protease inhibitors like borzatumab. Those are also the ones where intrathecal therapy with rituximab or methotrexate have been used, and they've seen partial responses. Yeah, if this were my patient, I would have used intrathecal therapy before.
Yeah, that's the only thing that we did not try. And what it helps a little bit, the hypothermia. Like if they're in the hypothermic range, they respond better. When the temperature goes above 37, they become very, very active.
Really? I haven't made any of those observations, so I can't help you. But the disease is obviously much more extensive than the ones that are coming to our attention. Kind of every month somebody reports a form frust. They see a funny disease, they decide to do a CSF, and it becomes positive. So the disease is kind of expanding, as is its description. So everything we say today is an evolution.
Thank you.
Yeah, I mean, it's a fascinating disease and so interesting. And at my hospital, our star patient was 18 months in the ICU. And so and several people had discussed discontinuing care along the way, and it was a major point of discussion. And it can be miraculous, seemingly miraculous, with extraordinary critical care and support and multiple tries of different therapies. They can, that patient eventually went back to university after 18 months and a year of rehabilitation. So it can be incredible when it works.
But again, that just reiterates, 18 months is an awful long time to permit iatrogenesis. It really does require superb care, and knowing when not to do things.
Yeah.
Because if you just continue intensifying therapy in something that has an unknown natural course, you'll likely kill the patient trying to be therapeutic, much like I think resistant status epilepticus.
Yes, again, Dr. Mark, please. From your experience, any superiority about plasma exchange over IVIG? What time to start after each other?
The answer is in the resource-rich, developed world that everybody gets Plex, okay? The recommendations are Plex over immunoabsorption, although that's not based on any particular literature. Immunoabsorption has been described as salvage therapy, mostly in Europe. It's something that could be considered. Again, Plex doesn't make a great deal of sense to me. I wouldn't put my money there if I had a limited resource. I would use rituximab much earlier.
Thank you. Thanks.
I have a different question about venous sinus thrombosis, maybe Walter. Experience with interventional radiology and in addition to anticoagulation. Can you speak to that? And
particular, we see 2 or 3 cases a year when CVST, and we don't, for us it's impossible to do mechanical thrombectomy. In some cases, we send to another institution. But I guess there is not a lot of evidence, but I guess that seems reasonable approach, no? And the best approach, I guess.
Mm-hmm. I think we touched on maternal fetal medicine. Can anyone want to talk about interactions with your maternal fetal specialists and the role that plays in developing your care plan?
Yeah, I think, so in our institution, they're really involved in every case that we have in the neuro ICU during pregnancy, and they're quite helpful. And depending on the risk for the fetus, they sometimes do initial monitoring, and then they say that looks okay, and you know disconnect, and we send the mother afterward to their ward, and sometimes we continue monitoring throughout. But for us, they've been extremely helpful on different aspects: medication, monitoring. And they have a team, and they have a nurse sometimes that they send at the bedside, especially for this high-risk patients, to spend it with them for the monitoring. So I think they're quite helpful.
Question here in the front.
Thank you very much. Another question for Dr. Engel. You're absolutely right about how memorable these cases can be. I remember every single case. I had 2 as a trainee, and I had 1 as an attending, and I remember their names and fine details still. There's one case that comes to mind where we decided as a team to do empiric bilateral oophorectomy without any evidence of a structural lesion or cyst. Like, can you give us your take on that? Is there any evidence, any specific recommendation, success maybe?
I participated in one atrocity like that, and I will die remembering it. I don't think there's any rule for speculative ovariectomy. I think that came during a period of time when we assumed that everybody had to have a teratoma to have the disease, and that's clearly not true. So I think you do a reasonable investigation. You may include PET if you have that opportunity, but to actually go ahead and do bilateral ovarectomies on otherwise normal ovaries speculatively is not medicine. But I'm highly opinionated, as you know, Rashid.
What if you have one ovary with cyst, suspicious, but OB don't want to resect it? You feel that maybe it could be a reason for the patient is refractory. Would you advocate for that, one side resection? know, we get a lot of those cases.
No, I get it. It's one of those, okay. If it's one ovary and there is pathology, and you think that contained within that pathology there might be some neural tissue with antibody expression, I'd go for it on a balance, okay? But yeah, I get it.
And there's a question from the audience.
Hello, everyone. I'm Sami. I'm one of the neurocritical care graduates. I was trained by Dr. Angle. So just to add on the oophorectomy thing, I had a recent case where a patient had a cyst on one side, but when I discussed with OB-GYN, I was like, maybe we should go for bilateral oophorectomy because there was evidence on one side. So they were arguing against it. So I would say maybe you should have a multidisciplinary team discuss. And I had a lot of resistance from OB-GYN. Like they're like, okay, let's try with one. But I was like scared and I was worried. I was thinking, okay, if I'm gonna go ahead, let's be aggressive and do bilateral oophorectomy. So did it help the patient? I don't know. She's still like admitted in the floor. We were able to wean her from the ventilator, but she still like has a lot of like myoclonus and her GCS remains the same. So I don't know if I benefited the patient anyhow.
Yeah, Sami, it's, you know, if it works, you take credit for it. If it doesn't work, you have nightmares. So I don't think I would do it again, that's all. But you're not wrong, but you just have to know what you can live with.
Yeah, but I know, like for example, OB-GYN, they're always thinking about, okay, the fertility and everything. But when you think about it, this patient has already been in the ICU for a very long time. She's not doing well. She's having like myoclonus. Like you see her neurological deterioration. So, you know, I thought about, okay, let's hit her hard and give her the best chance. She's already a mother of, like, for example, 2 kids. At least if she gains.
Okay.
So yeah, so that's, you know.
She has 10 kids. They're all girls. Kafaya, right?
Exactly. Yeah.
No,
so benefits.
Everything is situational. And the other thing that has to be said is it's not up to you to make the decision. It's up to you to have a team to disperse the responsibility. It's up to you to discuss it with the family and come together with a consensual decision, because they'll have to live with the decision as well, okay? You may not forget the name, but you won't live with the consequences. They will.
Yeah, I think in these very rare cases, you know, we don't get so many in each of our experiences, personal experiences. So it's so important to gather together, to discuss, to participate in the research studies as much as possible, to learn, you know, and again, we get, because we're a major referral center in a large hospital, we get maybe one a year. And in our star patient, as I said, you know, that was about 10 years ago, and I still remember exactly what we did, and I'm sure we did things wrong, or things that we would not do now in that experience that maybe prolonged her stay, but that's important for us to discuss these things so we learn from each of these cases, because we can't do that individually or even in our own hospitals. And in any case, I think we're just a little bit over. I think this is a great session. I certainly learned a lot. I hope everyone else did. And thank you very much for attending.